Hi, Bruce.
Hi there. Hi, Sue. Good all. Sure. To those of you watching this remotely, I apologize that we're recording before I've started. So just pay attention, or you can take another minute before we start. Actually, it won't be that long. I was going to start in a second. Okay, good afternoon. Welcome everyone to our town hall for Women's and Children's Program at Master Children's Hospital, Ron Joyce, and the Mumsy site. Thanks everyone for joining us at 2:30 on Thursday, the 18th of June. I'm Bruce Squires, Vice President of Women's and Children's at HHS, President of the Children's Hospital. Again, thanks everyone for joining. And I'm looking at one icon here that's showing flowers blooming. And I was just thinking about the fact that we are a couple of days from the conclusion of what I think is fair to say for many folks, the most professionally and personally different, disruptive, perhaps challenging spring that we've ever experienced. And you know, I think spring is kind of a time for renewal sometimes. So there certainly has been new. I hope again, and we've talked about this a few times, I hope all of us are able to look back and while seeing the challenges, while seeing in some cases some of the loss, while seeing you know, the pain that we've experienced, that you're also able to reflect on what you've accomplished and what we've done to support each other, but as importantly to support the patients and the families we serve. I always say it because I cannot say it enough how proud and how thankful I am, and I know all of our leaders are for the work and the efforts, the dedication, the passion that our teams have shown through this really difficult time. And you know, because of that feeling, I can also express the if you like, anguish that, you know, there's things that we haven't fixed yet that are very painful that are more painful for individuals and may and can feel very can feel unfair, can feel like people don't care, can feel I guess isolating, you know, feel like you're not being heard, and so you know, I guess what I can say there is that yeah, we're very aware and very concentrated on trying to address those things. So we'll talk about a couple of them in the questions, but also you know, acknowledging that we haven't fixed them. In some cases, I mean, some things have improved, but there's many things that are still a challenge. And so I know that I see it every day, the commitment of our leaders and in our teams to keep trying to fix those things. But I got to acknowledge that you know, there's still pain while those continue. So again, that's kind of referencing the spring part. We are going into summer. So I hope that that folks with this region opening up tomorrow, that's also going to be, from a personal and family perspective, that you're able to capture and enjoy that in whatever way works for you. So again, another town hall and another evaluation of last time's town hall. Only had about 20 people fill out the survey, which again, I completely understand. The most common comment was, get through the questions. So I'm going to get through the questions now. I'm just going to get as far as we can. So that's it for my intro. So starting off and just going with the numbers I was given. So I wanted to share with you my concerns about the current situation, restaffing and redeployment at the RJCHC. I am concerned, and they're not numbered, but bullet, about all of the families and children who are not receiving therapy services from their clinicians who know them best. About the inequities for our Hamilton families when children in other regions are receiving their usual therapy supports, mainly via virtual care, but some areas are ramping up to in-person visits. About the children who are sitting on our wait lists, missing the opportunity for early intervention just because they live in Hamilton. For example, there are 90 children waiting for physiotherapy services at the Ron Joyce Children's Health Center. About highly skilled clinicians doing screening instead of the work for which they are trained. About burnout of our staff, both the ones doing screening duties and the ones who are covering for them. There are only 4 physiotherapists, 3 FTE, providing care to 194 children with urgent needs this summer, with more urgent referrals arriving every day. The other physiotherapists are redeployed. Just one example of the therapy shortages at the Ron Joyce. Is there anything that can be done? When will the staffing at Ron Joyce return to a level sufficient to manage the needs of children and families requiring therapy services in Hamilton? Yeah, there are things that can be done, and the team is, and many of you are actively working on that. Part of that is to further ramp up and utilize virtual care, including team-based virtual care. But a big piece of that is also planning for the safe and effective return to on-site services at the Ron Joyce Center, as well as across the organization. So do I have a date yet for that? No, the team has not yet been able to identify a planned date for the reintroduction. For us to present then up to HHS, but kind of more challengingly to the region according to their the guidelines, and those guidelines change. So I don't have a date for that, but I can tell you that the teams are actively working to design approaches for how we'll be able to not return to exactly the way it was being done before, and I don't see that as the question that's being asked, or the sentiment of the question, but definitely to being able to increase and drive to an optimal delivery of those services that need to be done in person, and relative, and then using, where appropriate, those services that can be done virtually. We're also going to look at the extent to which we're able to deliver care in other venues, including child care centers, including, of course, the school system, and looking at whether there's possibilities around in-home as well, recognizing there's challenges that need to be worked through, but all of those pieces are on the table, at least in terms of planning. I can't tell you at this point, because I don't think anybody can, exactly what constraints, if you like, or permissions are going to be provided by the province, but we're going to keep actively working them. I'm wondering about the visiting policy. Can you please clarify the visiting policy for inpatients and surgical patients? And this is in pediatrics. Some parents are demanding they both be present post-operatively, and it causes other parents that are following the one-person limit to lash out and get angry. Can there please be a standard policy across the hospital? and then in brackets, except for special circumstances, of course. And I think there's a combination, so I'll read the next one. Now that some provincial restrictions are being lifted, can we extend visiting rules to allow parents in at one time? So right now, we continue, just to be clear, we continue with a policy that allows, as it relates to children and youth, one parent to accompany, and one parent in the NICU, but with an ability for those parents to be changed off, so that you've got the possibility for both. We also allow, or we're also in a position that a family caregiver or support person can be present with one of our obstetrical patients, in one of our moms in long-term, in labor and delivery, and in 4C. That's what's in place right now. The province has announced, and I think this is absolutely the right way to go, that those restrictions on family and caregiver presence need to be changed because it has a significant impact on the quality of care that patients and families receive. You all know, we all know the difference it makes. And so because of that, although we were about to make a minor adjustment to the visitation policy, and it was fairly minor, the entire corporation is taking it back with a goal to rolling out mid-next week a more significant, very significant adjustment to our family and caregiver visitation policy. I don't know exactly what that's going to look like yet. I know it will take us further in terms of the presence of caregivers in inpatient and in outpatient settings. I know that that poses some challenges, and in some cases poses a little bit of concern, and maybe for some even fear. And so our subject matter experts are looking at that very closely to make sure that we're doing what's appropriate to keep safe. But I will tell you at its heart, and I believe, and I think many, if not most of you also believe, that it is in the best interests of our patients and their families to be more supportive of their presence when they are in our buildings. So the rules will be extended next week. I can't give you the details yet because I don't know, but we're going to communicate that as soon as possible. But again, to give you the signal that I expect next week, we will be significantly extending. I was wondering why we're no longer being notified in the ER when we treat COVID-19 patients. I understand we are universally masking and using precautions for all patients. However, we are also doing extended use masking, which poses an increased risk of self-contamination. This is causing some anxiety as staff worry about patient-to-staff transmission, and staff are then going home to loved ones who may be immunocompromised. So I thought that was an important question. So we did ask our experts in infection prevention to provide a response. It's important to maintain patient confidentiality. The assumption is that any patient can have COVID or any other infectious disease, and therefore you must always do a risk assessment for risk of bodily fluid exposure as part of routine practice to protect yourself and therefore your loved ones. We are universally masking to help prevent the spread of COVID among staff and between staff, from staff and patients. Good hand hygiene and not touching the front of your mask are essential to prevent self-contamination. Thank you for your message in this week's Ask Bruce update in recognizing and admitting the heartbreak for, oh, sorry, that's a typo. So that's the end of the answer that was provided to me. So sorry, this is, normally I answer the questions, but where I've got somebody who wrote an answer for them, I want to read it for me. I want to read it well. So Michael Jean, former Governor General, spoke with CTV News expressing losing 4 members of her family who had to die alone. She stated, "The hurt stays forever. We should have done better." It was possible to accommodate even one family member, as we have done with essential workers, to allow a loved one to die in dignity. Even now in phase 2, healthcare clinicians are still screening rather than treating children, which could be done safely unable to even access our offices. Yes, we need to respect pandemic guidelines, but we need to keep in mind that there is a human element, which includes physical, psychological, and social impacts, which may have serious and lasting effects. Bravo to Sick Kids for their back to school recommendations, recognizing the lifelong impacts of isolation for kids. So there's not a question on that one. I want to echo that. I want to point out that we did have an opportunity to participate in the development of the Sick Kids recommendations. I'm kind of disappointed we weren't able to partner in the release, but I want to tell you how supportive, again, we are of course with balance, but escalating the importance of considering the need to get family and caregivers together with kids and to get kids back to environments that allow them to thrive and flourish. And people like our teams, you folks, are really the experts on that message. So I encourage you to continue to express it, and I'm going to continue to work to amplify it. I'm wondering about the door at the bottom of the stairwell in the south garage. Can we please prop open the door at the bottom of the south garage, as it is a handle and there is no hand sanitizer there? We need to use our device to show we have passed screening, good germs. So we can't prop open a fire safety door. We cannot do that. We are not allowed to. So sorry, I understand the question. I want to point out that there are hand sanitizers many places, and as you go from there, there are sanitizers on the way to the screening, as well as sanitizers when at other points by the elevators. So I really do want to encourage folks to continue to use hand sanitizer. The reason we haven't been able to put one there, and folks recognize this, is we are still in a period of shortage or restricted use on hand sanitizers. Fair question. Is it possible to add a third screener for staff, especially at shift changes and busy periods? It would ease the burden on the 2 screeners. Looks like everyone is respectful and the line is fairly quick. However, I'm at work early, so I am never pressed for time. Not everyone is the same. Thank you for your time and attention. And so thank you to Barb Jennings for helping here. The staffing plan is set and delivered by CSO. And we've gone with 2 screeners in the red section. Sorry, by the central staffing office and the central redeployment office. We have been fortunate, and big thank you to many of you, that we've had staff from clinics and from the emergency department and others who have come down at the start of their shifts to help with screening when we've needed it to fulfill flow. Now, some of those folks have been pulled back. And I gather there was a problem at the start of this week because we had a little bit of confusion around scheduling, and we had someone who was not able to come in with their shift. I believe and understand we're back on track. And so believe that the lines have been, or any delays have been quite minimal. But I also want to highlight at this point that as I've committed and discussed with you a number of times, really believe that there is not so much of a need to ask you as professionals, staff and physicians, when you are diligently applying self-screening using a checklist tool, which helps with effectiveness, to also ask you to go through screening. In the next couple of days, we will be announcing the change early next week that will move away from staff also at Mumsy site as a pilot from also having to go through a screening booth. It will rely on you and ask you to use your self-screening tool and then to make your way through one of the dedicated doors, either through an elevator or through the designated doors. And those will be named in the communication. A part of that will also involve ensuring that you have a mask in a safe way, you've taken home the night before so that you can arrive masked as per requirements. So more communication specifically to come on that, and I'd ask you to rely on that communication with your managers. But I want this group to know, I've talked about it many times, that we are moving to the point that I think is appropriate and respectful, that will rely on you using a checklist, because that's an appropriate safety measure that we know well from high reliability organizations, to help you to do that assessment every day, but relying on that and not asking you also to go through screening. Why are screeners being told to use vacation days when the scheduler is overbooking? Why are the screeners' schedules not fair, even fair? E.g. booked for 2 nights, 1 day, and then 5, 6, 7 more night shifts. Not having more than 1 day off in a work span. So obviously this is really expressing concerns that reflect the significant challenges we're still having with this new role, this very dynamic and ad hoc role with the relatively small number and very, very focused from our teams role. So I want to say that there's huge efforts that have been happening and continue to happen with the screening office that is working on this. It is extremely challenging. I also want to say that we are actively moving to a different approach, and so we're on our way to being able to fill the screener roles, I hope, in a different way that won't require folks to be redeployed. There was a question that I don't think you hear now about whether folks are eligible for overtime in these situations, and as the situation is appropriate as to normal roles, yes, all of those payments would apply. But the crux of this question is it doesn't feel fair yet, so make it fair. And we are absolutely, I see the individuals working that, and I really, the efforts that they're making have been really Herculean. I think the changes that we're going to make to staff scheduling will help there, and moving to dedicated individuals for that role should help significantly. Would you be able to provide an update as to how the Ron Joyce in particular will be redesigned to allow for bracket social distancing, client space, client treatment space, office space for staff? So I can't give the specifics yet on exactly what the redesign will look like. No, I can't tell you that. You know, everywhere across the organization, we have to think about, in a short period of time, you know, what adjustments can we make? And so, you know, that's going to be probably a bit variable depending on the location. You will notice in some other venues that masking will have to suffice where we can't be separate from our families, where we can't be separate from our colleagues by more than 6 feet. There's going to be times where, and there is now in much of the open community, where other mechanisms to ensure protecting against transmission of disease, which is hand washing, which is face masking, which is you know, ensuring appropriate screening, are what will be involved. So that's going to be that's in some areas, that's going to be one piece of that we all will need to consider, not only in our work environment but in our private lives. Other pieces, though, will be, how do we adjust the location of desks? How do we adjust how we line up the treatment rooms? So no, we have not yet been able to design exactly what that will look like. The teams are working on that now. Can you speak to offering virtual services as we begin to provide face-to-face service again? Specifically, it will be offered where appropriate and allow staff to work remotely to do so, given the benefits of this model. Appreciate this meetings every week. Thank you for offering them to staff. So thank you for attending. Yes, absolutely, virtual will be offered. my view is that we have to provide some mechanisms where virtual care can be done in places other than our traditional treatment space. Because if we keep using up treatment space or office space, then we're probably not optimizing. So in my view, that involves, in many cases, the use of things like home or other venues. Exactly how we'll do that, I don't know yet. But my sense is that there are going to be places where absolutely we will need to facilitate what you're doing now. Many of you are providing services from home right now in terms of care. So if we can do it now, why can't we figure out ways to do it going forward? Not sure if this has been asked yet, but just wondering what has been put in place to make our pandemic processes more streamlined, or what will we take from this experience, making the process less jarring? Thank you and have a great day. That's because they hit me with a very, very hard question. I mean, I think it's something that every single level of institution is wrestling with, globally, nationally, provincially, regionally, locally, and even in your own families, we're wrestling with this, right? I think that we've definitely identified mechanisms to mobilize for quick response, and what are some of the key preps to make for quick response, including in terms of the identification of teams for critical areas, such as, again, in these cases, our critical care areas, being able to do emergency departments, and very critically, being able to deal with congregate settings. And so, you know, teams and care models have been put in place to ease that piece. Yeah, so I could go on and on that one, but it's a really great question, and I think we're across the board, we're looking to document those things. The hospital protocol for working remotely does not cover expenses incurred while working remotely. My manager is trying to assist in this area, but not having much success, and she is unable to provide a timeline for resolution of this issue. I would appreciate if this could be addressed sooner rather than later, as we're expected to complete several virtual visits a day, and this adds up to several hours on my personal phone. So I agree, and so I'm going to escalate this one as well to try and get an answer. I don't know yet if we've, well, I do know we haven't been able to work this through, and this requires clarification, not only a bit locally, but a bit provincially. So I agree, and I'm going to look to take that forward. So 257. So I hope I did a better job of getting through more questions this time. Let me close with two things. I want to read a couple of the celebrations because they're really great. And these came from you. So interprofessional collaboration and working with more individuals at HHS than ever. This is somebody celebrating that with 2 exclamation points at the end. Just all the screeners from Ron Joyce who continue to support the corporation despite crazy schedules, like 7 night shifts in a row, 1 day off, and the often terrible responses they may receive from staff and in capital letters, visitors and patients. That's been horrible. I'd like to celebrate all our redeployed colleagues who've gone into new environments that are not their own, working with people they don't necessarily know, working with new client populations, and who may be dealing with issues they've never encountered before, and are doing it with professionalism and grace. Hallelujah. How about someone who does not get celebrated so much, like the folks who are picking up our garbage and cleaning our toilets, the ones keeping the AC and the power on, delivering and sending the mail? Just an idea to celebrate those small services or forgotten services of our amazing team. Again, hallelujah. Those folks have been turning on a dime throughout the last 4 months. So I really echo that celebration. So we've been doing a draw each week. So I want to close with a draw, and to be clear, anyone we heard from, we put in this little bucket. These are donated M&M, which is that frozen meat group gift cards, and they do curbside delivery or curbside pickup. So Jackie Bultius, I think that's how you say your name, Jackie, who's an RN in PACU. So congratulations for one of those. I hope, and I think they do Beyond Meat as well as just meat, just to be clear. So you can be a vegan as well, I think. Leanne Goss, who's a business clerk in the OR. Thank you, Leanne. And last but not least, Caitlin Ingram in our PICU. An RN in our PICU. So those are the three kind of successful this week. 3 o'clock, so I did it. Thank you very much, everyone. Thank you again for all you do. And I wish you a happy end of spring and a happy start of summer. So have a great night.